talk, Dr. Bhaskar Choudhary. We are very privileged to have him today. He's a senior cornea cataract specialist, and he is the director of Tamanash Eye Foundation in Kolkata with more than 20 years of experience in cornea and ocular surface work. And he is also the one who has given us the Amserter, a very easy to use device for amniotic membrane grafting in severe cases. So over to you, Dr. Roy Choudhary, for your talk on amniotic membrane grafting in 2 minutes, simplifying the management of acute ocular surface burns and SGS.
Thank you, Sushmita. I hope my slides are visible.
Yes.
Okay. We all, as ophthalmologists, we have been long associated with the human amniotic membrane transplantation. And we know that we are interested only in the amniotic membrane and particularly in the stroma of the amniotic membrane, not much in the cells of the amniotic membrane. So wide use of amniotic membrane in ocular surface reconstruction with slit and clot, and as a conjunctival substitute for reconstruction of conjunctival defects following removal of pterygia. The main uses of HAM, where it really makes a difference in the patient's care, are acute chemical burns of the ocular surface and acute Stevens-Johnson syndrome. So we know that amniotic membrane transplantation is particularly useful in grade 4, 5, and 6 of chemical burns according to Dua's classification. And in acute SJS, we know that there is a war on the ocular surface. So everything is damaged: epithelium, goblet cells, stem cells. And as per the grading of Darren Gregory, severe and extremely severe cases benefit from amniotic membrane transplantation if it is done within 48 hours. And these gradations are more than 1/3 of the lid margin taking stain or any epithelial defect on the cornea, and a stain positive greater than 1 centimeter in the palpebral or bulbar conjunctiva. So the conventional way of doing an amniotic membrane transplantation is, of course, overlaying the amniotic membrane on the eye and then tucking it with a blunt instrument and suturing it to the lids using bolsters, and then finally put in a conformer. But this job done at the ICU, often with topical anesthesia or without any anesthesia, and it is extremely painful for both the patient and the surgeon. There are certain devices in the market, like the Procera is widely used. It is manufactured and marketed by Dr. Shepherd Singh. But the problem with Procera is that it covers only a small area of the eye, only up to 2 millimeters beyond the limbus. So we felt that there was an unmet need, and for that we decided to go in for a device which could be readily assembled in the on the bedside. So for that, we went through certain design evolutions and finally came up with a 2-ring device, a bottom part and a top part, whose assembly and use I will be showing today. So this is the dimensions of the device. It is 24 mm wide and 20 mm in height, elliptical, and there is a notch on the bottom ring. So we have only one size, and whatever experience we had till now, including pediatric cases, we find that this size fits all. So we have not really had the case for developing another size. Now, first I will show you on the left of your screen the dry assembly of the device to understand what actually happens. So you can see the notch was shown by the forceps. Now the top ring comes and it snap fits into the bottom ring. So after this, you will see how to attach an amniotic membrane, and you can see that this device is fairly compressible. This is why it can fit in almost cornices of almost any size. So you tuck the bottom ring below the amniotic membrane, and it has to be kept wet all the time. And you bring the top ring and sandwich the amniotic membrane in between. This is an alternative technique in which, if you do not want raw edges of your ring to be exposed, then you can put the ring on top of the membrane and gather all the amniotic membrane inside, and then put the top ring, and then this entire ensemble, it can be inserted like a contact lens. And this assembly can be done anywhere. It can be done at the bedside or in the eye bag. So here is a small video of its use, courtesy Dr. Rishi. And you can see that the surgeon is holding it in his hands and simply moving it in and placing it in the fornix. And when he'll remove the speculum, lid retractors, there is no problem in lid closure. It can close easily. So this is another use in a pediatric case of SJS by Dr. Bhupesh. And you can see that it is being assembled on the gloved hand of the surgeon. Although ideally this should be done under microscope on the inside the OT, and then you can carry it in the carrier for amniotic membrane and take it. Now you can see what Dr. Bhupesh is doing is he is taking the extra part of the amniotic membrane beyond the ring and draping it over the lids. So if you want to give lid cover, this is also available. So this is a case of recurrent pterygium, had 2 recurrences, and there was a dense adhesion in the medial, near the medial canthus, with both lids, dense semilifera, so much so that the patient had a diplopia in primary position. Now, after doing a normal conjunctival autograft and releasing the semiliferon, we did not go for any cover of the raw lid surface. Instead, we put in the amniotic membrane inserter. So this can be easily placed with the forceps, and it covers the lid very snugly and prevents semilifera. So these are the results. You can see that the amniotic membrane, this is the first post-op day picture. You can see it sits very nicely. There are no problems of lid closure. And you can see how the patient improves from, and the patient is completely devoid of diplopia and recurrence now. This was our first case, a 14-year girl with acute SJS, and we did an amniotic membrane grafting in the ICU using the Amserter. And the very first post-op day, you can see that the semilifera do not develop. And this is the 14-day post-op. You can see that even with the amniotic membrane in the eye, you can see the cornea and anterior segment details pretty clearly. This is another case of Amserter in a chemical injury. And this is another use of amniotic membrane inserter in a case of Chuna injury. And these are the results. This has been used in large epithelial defect, corneal epithelial defect following chemical injury. So the advantages, to sum up, is the elliptical design which conforms with the shape of the fornix. It is deformable yet with good memory, and it is not brittle. We have tested it in minus 80-degree storage also. It does not become brittle. You can mount an extra AM. We have used up to 3 layers of amniotic membrane, and you can apply glue on the undersurface, although it is not needed. So is the job done? Well, I think that we need to educate critical care specialists and dermatologists and also ophthalmologists about the availability of the procedure, which will really make a difference to the lives of the acute SJS and chemical injury patients. Thank you.